Hi, my name is Dr. Hussein Hadi from the Department of Pathology and Forensic Medicine at Mustansariya University. This is a series of three lectures at which the lymphoreticular system will be addressed from the pathological point of view. In the last lecture, we already started the discussion about the malignant lymphoma, highlighted in more details its major subdivisions, mainly Hodgkin's lymphoma subtype. Today is the last lecture of this series, at which the non-Hodgkin's type will be addressed in more details. As we addressed in the last lecture, the molecular studies have shown that Hodgkin's lymphoma is a tumor of B-cell origin and characterized morphologically by the presence of distinctive neoplastic giant cells called red Sternberg cells. Conversely, the non-Hodgkin's lymphoma are regarded as a large group of clonal lymphoid tumors. About 85% are of B-cell origin and 15% of T or natural killer cell origin. They are characterized by an irregular pattern of spread, and a significant proportion of patients develop extranodal disease. The etiology of the majority of cases of non-Hodgkin's lymphoma is unknown, although infectious agents are an important cause in particular subtypes. We mentioned that the etiological causes for the majority of cases of non-Hodgkin's lymphoma is unknown. However, the infectious agents such as viruses, bacteria, and protozoa may have a crucial role in the causation of particular lymphoma subtypes. As indicated in this table, viruses such as Epstein-Barr virus may develop Hodgkin lymphoma and Burkitt lymphoma, which is regarded as non-Hodgkin's lymphoma. Other viral infection is the HIV-1, which can cause Hodgkin lymphoma, high-grade B-cell lymphoma, which is regarded as non-Hodgkin's subtype, or even primary CNS lymphoma. In addition, hepatitis C virus may cause the marginal zone lymphoma. For the bacterial infection, Helicobacter pylori may have a crucial role in the causation of gastric lymphoma. Malarial infection can also cause Burkitt lymphoma. Regarding the cell of origin, there is either B or T cell lymphomas. B cell lymphomas tend to mimic normal B cells at different stages of development, whereas T cell lymphomas resemble precursor T cells in bone marrow or thymus, or peripheral mature T cells. Classification of non-Hodgkin lymphoma. The lymphomas are classified within a group of mature B cell and T cell neoplasm. For many years, clinicians have subdivided lymphomas into low and high-grade disease. In general terms, the low-grade disorders are relatively indolent, respond well to chemotherapy, but are very difficult to cure, whereas high-grade lymphomas are aggressive and need urgent treatment but are often curable. The best example for low-grade lymphoma are the follicular lymphoma and mantle cell lymphoma, while the diffuse large B-cell lymphoma and Burkitt's lymphoma are regarded as high-grade lymphomas. What are the WHO classification of lymphoid neoplasms? The WHO classification of lymphoid neoplasms considers for each entity the morphology, cell of origin, which is determined by immunophenotyping, clinical features, along with the genotype, for example karyotype and presence of viral genomes. And these are Hodgkin lymphoma and non-Hodgkin's lymphoma. The non-Hodgkin's lymphoma is subdivided into first, precursor B-cell neoplasms called the precursor B-cell leukemia or lymphoma. These are the neoplasms of immature B-cells. Secondly is the peripheral B-cell neoplasms. These are the neoplasms of mature B cells. The third subtype is the precursor T cell neoplasms, called the precursor T cell leukemia or lymphoma. These are the neoplasms of immature T cells. Finally is the peripheral T cell and natural killer cell neoplasms. These are neoplasms of mature T cells and natural killer cells. This table lists the peripheral B cell neoplasms as well as peripheral T cell and natural killer cell neoplasms. The examples for the peripheral B cell neoplasms include chronic lymphocytic leukemia and small lymphocytic lymphoma, B cell pro-lymphocytic leukemia, lymphoplasmacytic lymphoma, splenic and nodal marginal zone lymphoma, extranodal marginal zone lymphoma, mantle cell lymphoma, follicular lymphoma, along with the hairy cell leukemia, plasmacytoma and plasma cell lymphoma, diffuse large B-cell lymphoma, and Burkitt lymphoma. In this lecture, we will try to outline the follicular lymphoma, mantle cell lymphoma, marginal zone lymphoma, as well as the lymphocytic lymphoma. These subtypes are regarded as low-grade non-Hodgkin's lymphoma. In addition, we will try to discuss the diffuse large B-cell lymphoma and Burkitt lymphoma as an examples for the high-grade non-Hodgkin's lymphoma. The T-cell lymphoma are less common and include mycosis fungoides, peripheral T-cell lymphoma, anaplastic large cell lymphoma, and enteropathy type T-cell lymphoma, and other subtypes. I said we need to focus our discussion on a subset that are particularly clinically important or pathologically illustrative. Some neoplasms are common and collectively make up the vast majority of lymphoid neoplasms, more than 90%. These include, first, precursor B and T cell lymphoblastic leukemia or lymphoma, commonly called the acute lymphoblastic leukemia. Secondary is the small lymphocytic lymphoma, chronic lymphocytic leukemia. Thirdly is the follicular lymphoma, mantle cell lymphoma. Next is the extranodal marginal zone lymphoma, along with the diffuse large B-cell lymphoma, Burkitt's lymphoma, multiple myeloma, and the Hodgkin's lymphoma. The clinical presentations of patients with non-Hodgkin's lymphoma include superficial lymphadenopathy as an asymmetric painless enlargement of lymph nodes in one or more peripheral lymph node regions. In addition, the patients may have constitutional symptoms such as fever, night sweating, and weight loss occur less frequently than in Hodgkin's disease. Oropharyngeal involvement may occur, as well as organs involvement, at which the liver and spleen are often enlarged. The gastrointestinal tract is the most commonly involved extranodal site after the bone marrow. Also, skin, brain, testis, or thyroid can be involved. Other clinical features due to anemia, neutropenia, or thrombocytopenia. Here are the main clinical differences between Hodgkin and non-Hodgkin lymphomas. For the Hodgkin lymphoma, it is more often localized to a single axial group of nodes, mainly cervical, mediastinal, or para-aortic nodes, whereas the non-Hodgkin lymphoma have more frequent involvement of multiple peripheral nodes. In addition, orderly spread by contiguity is the feature of Hodgkin lymphoma, while the non-contiguous spread is the feature of non-Hodgkin lymphoma. The mesenteric nodes and Waldeyer's ring rarely involve in Hodgkin lymphoma, but these sites are commonly involved in non-Hodgkin lymphoma. Finally, the extranodal involvement are common in non-Hodgkin lymphoma as compared with the Hodgkin subtype. In order to investigate a patient with non-Hodgkin's lymphoma, histological examination of lymph node biopsy or other involved tissue is the definitive investigation. In addition, morphological examination is assessed by immunophenotypic and genetic analysis. A fine needle aspiration may also be performed to exclude other causes of lymphadenopathy, such as tuberculosis or carcinoma, but is not useful in establishing a diagnosis of lymphoma. Other laboratory investigations may be performed, especially in advanced disease with marrow involvement. There may be anemia, neutropenia, or thrombocytopenia. In addition, lymphoma cells, for example mantle zone cells, cleaved follicular lymphoma, or blast cells, may be found in the peripheral blood in some patients. Other laboratory examinations include trephine biopsy of marrow to see if there is bone marrow involvement, increased LDH and uric acid, along with the immunoglobulin electrophoresis, which may reveal a paraprotein. At this point, we will try to discuss the specific subtypes of non-Hodgkin's lymphoma, especially the low-grade and high-grade forms. To start with, the low-grade non-Hodgkin's lymphoma subtypes will be considered, and these are: first, follicular lymphoma; secondly is the mantle cell lymphoma, followed by the marginal zone lymphomas and lymphocytic lymphomas. So, first we will discuss the follicular lymphoma. The follicular lymphoma accounts for 40% of adult lymphomas. It is often characterized by a benign course for many years. Greater than 85% of follicular lymphomas have a characteristic 14-18 translocation that fuses the BCL2 gene on chromosome 18 to the immunoglobulin heavy locus on chromosome 14 and leads to the inappropriate expression of BCL2 protein, which functions to prevent apoptosis. In addition, whole genome sequences of follicular lymphomas has identified additional mutations in gene encoding histone-modifying proteins in about one-third of cases, suggesting that epigenetic changes also contribute to the genesis of these tumors. Follicular lymphomas occurs predominantly in older persons, rarely before age 20 years, and affects males and females equally. It is important to know that the natural history of follicular lymphoma is prolonged, with median survival of 7 to 9 years, but it is not easily curable, a feature that is common to most of the indolent lymphoid malignancies. However, in about 30 to 40% of patients, follicular lymphoma progresses to diffuse large B-cell lymphoma. Follicular non-Hodgkin's lymphoma usually presents as frequently generalized painless lymphadenopathy as seen in the right picture. The patient may develop extranodal disease, such as follicular lymphoma involving the scalp. These microscopic images show the follicular lymphoma. Here is a lymph node involved by lymphoma, a malignant process characterized by the proliferation of neoplastic lymphoid cells. The capsule of the node has been invaded and the lymphomatous cells extend into the surrounding adipose tissue. Note that the follicles are numerous and irregularly sized. At high magnification, small lymphoid cells with condensed chromatin and irregular or cleaved nuclear outlines, these are the centrocytes, are mixed with the population of larger cells with the nucleoli, which are the centroblasts. The second subtype is the mantle cell lymphoma. It is associated with the chromosomes 11-14 translocation that results in overexpression of cyclin D1. It is of aggressive behavior. Next is the marginal zone lymphomas, are typically extranodal. In fact, mucosa-associated lymphoid tissue lymphomas come into this category at sites such as the stomach or thyroid. Gastric mucosa-associated lymphoid tissue lymphoma is the most common form and is preceded by Helicobacter pylori infection. Other is the lymphocytic lymphomas. The lymphocytic lymphomas are closely related to chronic lymphocytic leukemia. If the peripheral blood lymphocyte count exceeds 5,000 cells per microliter, the patient is diagnosed with chronic lymphocytic leukemia. Most cases fit the diagnostic criteria for chronic lymphocytic leukemia, which is the most common leukemia of adults in the Western world. By contrast, small lymphocytic lymphoma constitutes only 4% of non-Hodgkin's lymphoma. For unclear reasons, chronic lymphocytic leukemia and small lymphocytic lymphoma is much less common in Asia. Here are pictures that show the examples for mucosa-associated lymphoid tissue lymphomas. The gastrectomy specimen, as seen in the left image, shows a thickened stomach wall as indicated by an arrow from mucosa-associated lymphoid tissue lymphoma with a well-demarcated ulcer. The right image is for the mucosa-associated lymphoid tissue lymphoma of a small bowel. Now we will address the high-grade lymphoma, mainly the diffuse large B-cell lymphoma and Burkitt's lymphoma. So first is the diffuse large B-cell lymphoma. It is the most common type of non-Hodgkin's lymphoma, accounting for approximately 35% of adult non-Hodgkin's lymphoma. It is considered as a heterogeneous group of mature B-cell tumors that share a similar large cell morphology as well as aggressive clinical behavior. About one-third of diffuse large B-cell lymphomas have rearrangements of the BCL6 gene, and an even higher fraction of tumors have activating point mutations in the BCL6 promoter. Both aberrations result in increased level of BCL6 protein, an important transcriptional regulator of gene expression in germinal center B cells. Another 30% of tumors have a chromosome 14-18 translocation involving the BCL2 gene that results in the overexpression of BCL2 protein. Some of these tumors may represent transformed follicular lymphomas. The remaining tumors have other diverse drive mutations, such as translocations involve the MYC gene. Patients with diffuse large B-cell lymphoma typically present with a rapidly enlarging, often symptomatic mass at one or several sites. Extranodal presentations are common. As seen in these images, there are multiple dome-shaped erythematous cutaneous nodules on different sites in the neck, trunk, or genital area. The second subtype of high-grade lymphoma is called Burkitt's lymphoma. Burkitt's lymphoma is one of the most highly proliferative subtypes of any tumors. It is associated with the translocations of the c-MYC gene on chromosome 8 as a result of translocation of chromosome 8 and 14. There are either endemic or sporadic cases. Essentially, all endemic tumors are latently infected with Epstein-Barr virus in endemic areas, and concomitant endemic malaria or other infections impairs immune competence, allowing sustained B-cell proliferation. Typically, the patient, usually a child, presents with massive lymphadenopathy of the jaw, which is initially very responsive to chemotherapy, although long-term cure is uncommon. In African patients with endemic tumors, involvement of the maxilla or mandible is the common mode of presentation. However, sporadic cases that may occur elsewhere in the world affects mainly children and adolescents. It forms abdominal tumors involving the bowel, retroperitoneum, and ovaries. It is essential to know that Burkitt's lymphoma may be seen primarily in association with HIV infection and often occurs as the initial manifestation of the disease. This picture shows a fungating mandibular tumor that ulcerates through the skin. Facial involvement is a feature of endemic form of Burkitt's lymphoma. This karyotype of 46XY translocation between chromosome 8 and 14 demonstrates the translocation typical for Burkitt's lymphoma. This is one of the most common lymphomas in Africa and most often appears in children. It is said that T-cell lymphoma are less common and include mycosis fungoides, peripheral T-cell lymphoma, anaplastic large cell lymphoma, or enteropathy-associated T-cell lymphomas, and others. At the end of the lecture, we should know the clinical staging of Hodgkin and non-Hodgkin lymphomas, called an Arbor classification. It is of 4 stages. Stage 1 is the involvement of a single lymph node region, or involvement of a single extralymphatic organ or tissue. Stage 2 is the involvement of 2 or more lymph node regions on the same side of the diaphragm, either alone or with the involvement of limited contagious extralymphatic organs or tissue. For the stage 3, it is characterized by the involvement of lymph node regions on both sides of the diaphragm, which may include the spleen, limited contagious extralymphatic organ or site, or even both. The final stage is the stage 4, with multiple or disseminated foci of involvement of 1 or more extralymphatic organs or tissues, with or without lymphatic involvement. In addition, all stages are further divided on the basis of the absence, letter A, or the presence, letter B, of the following systemic symptoms include significant fever, night sweats, along with unexplained loss of more than 10% of normal body weight. Here are some suggested readings. Hopefully you will find it useful for you. This is the end of the lecture. Thanks for your attention.